Obstetric nursing involves managing two distinct physiological transitions simultaneously. Every maternal labor assessment must be balanced against the fetal response to uterine forces. The clinical challenge is identifying the narrow window between expected physiological changes and the early indicators of a system in distress. All nursing interventions map to a specific triage hierarchy. In the birthing room, your priority framework is fixed: maintain the maternal airway, control maternal hemorrhage, and resolve fetal distress. Clinical judgment for the NCLEX and active practice depends on recognizing predictive patterns across the final stages of labor. We will begin with the second stage of labor, analyzing maternal biomechanics and the trajectory of fetal descent. In the third stage, we evaluate the pharmacological management of the placenta and the prevention of hemorrhage. Finally, we map the dual requirements of the fourth stage: maternal vascular recovery and immediate neonatal stabilization. Organizing your assessments into this chronological sequence allows you to recognize clinical complications before they escalate into an emergency. The second stage of labor begins at full cervical dilation and ends with the birth of the newborn. While dilation is 10 centimeters, the maternal urge to push is primarily triggered by fetal station as the head descends into the pelvis. Traditional hospital protocols often default to the supine or lithotomy position, where the client lies on their back with their legs in stirrups. This posture causes aortocaval compression, where the heavy uterus restricts blood flow through the maternal aorta and inferior vena cava. This leads to maternal hypotension and a direct drop in fetal perfusion. Upright and squatting positions utilize gravity to facilitate fetal descent, aligning the fetus with the birth canal. Moving upright physically increases maternal pelvic dimensions, providing more space for the fetal head, lowering compression risks and reducing the second stage duration. To conserve maternal energy, clinicians utilize delayed pushing. After reaching full dilation, the nurse may wait up to 2 hours to allow for passive fetal rotation and descent. This passive descent period is essential for patients with epidurals, who may not feel the natural urge to bear down, despite being fully dilated. When active pushing begins, avoid closed glottis or Valsalva maneuvers, where the client holds their breath. This increases maternal exhaustion and creates non-reassuring fetal heart rate patterns. Encourage spontaneous, open glottis pushing, breathing through the contraction while bearing down. If a client feels a strong urge to push before 10 centimeters, immediately perform a vaginal exam to ensure the cervix won't tear. Aligning labor positions with pelvic anatomy reduces the incidence of perineal trauma, operative deliveries, and fetal distress. You are watching for the 3 hallmarks of placental separation: a sudden gush of vaginal blood, the umbilical cord lengthening, and a firm globular fundus. Postpartum hemorrhage is the primary threat during this stage, typically caused by uterine atony or retained placental fragments. Active management of the third stage uses pharmacological intervention to stimulate uterine contractions and minimize blood loss. This grid shows 4 uterotonics. Oxytocin is the first-line medication to prevent atony. Methylorganovine is a secondary agent that triggers vasoconstriction. Because it raises pressure, it's strictly contraindicated in patients with hypertension or a history of stroke. Carbaprost is a potent prostaglandin causing bronchoconstriction. It's contraindicated for asthma. Misoprostol is safe for hemorrhage control, but avoid alongside magnesium-containing antacids due to interactions. Focus on these associations. Link methylorganovine with high blood pressure risks and carbaprost with pulmonary complications. Selecting a uterotonic requires cross-referencing the drug's mechanism with the patient's comorbidities to avoid inducing a secondary crisis. Once separated from the placenta, the newborn must clear amniotic fluid from the lungs to establish independent respiration. The APGAR score, taken at 1 and 5 minutes, provides a standardized assessment of this transition, measuring heart rate, respiratory effort, muscle tone, reflexes, and color. Expected findings include a heart rate over 100, a respiratory rate between 40 and 60, and active muscle flexion. An APGAR score of 9 is common and healthy. Most newborns lose 1 point for color because of acrocyanosis, blue extremities caused by peripheral vasoconstriction. Monitor closely for signs of respiratory distress, such as nasal flaring, expiratory grunting, or central cyanosis around the mouth. Respiratory success depends on temperature stability. cold stress triggers a metabolic cascade that consumes glucose and oxygen, leading to hypoglycemia and hypoxia. Newborns lose heat through 4 vectors: evaporation from moisture, conduction to cold surfaces, convection from air currents, and radiation to nearby cool objects. Drying the infant immediately stops evaporation. Skin-to-skin contact provides a heat source that blocks conduction and radiation. Stabilization also requires 2 prophylactic medications: vitamin K to prevent fatal bleeding from a sterile gut, and erythromycin ointment to prevent neonatal ophthalmia and blindness. Maintaining a neutral thermal environment is the foundational requirement for internal cardiopulmonary adaptation to succeed. The 4th stage is the first 2 hours postpartum. Maternal risk for hemorrhage is at its highest during this period of vascular transition. The baseline assessment for a stable patient is a firm midline fundus at or below the umbilicus with moderate lochia rubra. Uterine atony, where the muscle fails to contract, is the most frequent cause of postpartum hemorrhage. On the left, a contracted uterus compresses internal blood vessels to stop bleeding. On the right, a boggy, soft uterus lacks the tone to clamp those vessels, allowing hemorrhage. Bladder distension physically threatens uterine tone. A full bladder swells, pushing the uterus upward and deviating it to the right, mechanically preventing the muscle from contracting. If the fundus is boggy, massage it immediately to restore tone. If the fundus is deviated, assist the patient to void or perform a straight catheterization to remove the mechanical obstruction. Quantifying blood loss is essential for early detection. We use the QBL metric. Every gram of pad weight is equal to 1 milliliter of blood lost. Addressing a postpartum hemorrhage requires immediate mechanical intervention, massage, and bladder emptying to manually restore uterine tone. These 5 rules summarize the critical judgment required during the labor and delivery transition. First, prioritize delayed pushing and upright positioning to use gravity and protect fetal perfusion. Second, know your uterotonic contraindications. No methyl-ergonavine for hypertension and no carboprost for asthma. Third, for a boggy fundus, massage immediately. If it is deviated to the right, empty the bladder. Fourth and fifth, block neonatal heat loss through drying and skin-to-skin contact, and administer vitamin K to prevent internal hemorrhage. Success in the birthing room depends on anticipating the physiological cascade so you can resolve complications before they reach a point of crisis.